want to put these patients on because there's so many variables to consider, and they're different than the other patients that we treat because for the most part they're palliative or dying. So the decision making is more shared with the patient, and I find it difficult because each patient is very unique. And the second theme is really the multidisciplinary care piece, which helps in that decision making. And it's become more and more prevalent in the last number of years because of the advancements that have taken place in radiation and also in medical oncology. So I find I work quite extensively with my oncology colleagues, much more than I used to, say, 10 years ago. And then specifically, we're going to talk a little bit about current management. And I think as surgeons, we need to not know every targeted therapy known to mankind, and we don't need to know the details of radiation at specific doses, but we do need to have an idea of the concepts or availability of certain treatments so that we can challenge the oncologist and certainly make it part of our treatment if it's indicated. Surgically, I'm going to talk a little bit about separation surgery because I think you guys wanted to hear about that. And then I'll finish with a bit about patient evaluation because that's quite critical, I think, that we evaluate the work we're doing. And then lastly, I have some cases, or we can just discuss any topic you guys want. So coming back to that decision-making theme, we used to have lots of tools to try and help us with this decision-making. The literature had a lot of them, Bauer, Takahashi, Tomita, and they were all scales that tended to be based on patient prognosis and helped us to guide treatment. But people began to question the value of them as our technology surgically changed with vertebroplasty or kyphoplasty, minimally invasive surgery, and then the different drugs and radiation. So when they actually looked at it, none of these scoring systems that we used to depend on were valid. And people began to look at, well, why aren't they valid? And it's, as I just mentioned, there's just so many new things happening with tumor biology and technology for us surgically that there is options that just were not available in the past. So really, we shouldn't be relying on those classifications or those treatment decision-making tools anymore. We have to get into a new era. Now, why is that? And this was an interesting study that Benny Dahl and his group in Denmark did back in 2013. And they have a captive audience. All the metastatic patients within the country went to one hospital and they could study them longitudinally. And what they found was that the lung cancer patients and the renal cell cancer patients were living a lot longer than they used to. And the reason for that was the molecular markers and the targeted therapy that could be provided to some of these patients. So not every renal cell and not every lung cancer was living longer, but specific groups were that had markers that would allow targeted therapy. So the issue there became that, and I'm not sure how you guys used to be or with lung cancer, but that was all a histology that surgeons turned away from because the life expectancy was very poor. Their performance status was generally poor, and they tended to do not well with surgical intervention, so they often went on the palliative course. Well, if we treat every lung cancer the same now, we will end up under-treating patients who could have their quality of life dramatically altered and improved for their remaining time. So it's very important not to generically look at kidney cancer or lung cancer. We've got to specifically look at the various markers associated with them. And now we have to look at different types of lung cancer. And this was a paper we did a while back, I think in 2016, where we looked at a systematic review of the various survivals in lung cancer patients. And you can see there that if they are EGFR positive in the non-small cell lung cancers, these patients live almost twice as long as the other types of non-small cell. So this is really an important thing. If your patients have this marker, you would treat them much differently than you would, say, a squamous lung cancer. This is another example of just that. I don't think many of us would consider surgical intervention in this particular patient with melanoma. Widespread metastatic disease. The original tumor site was 2 years earlier, and it had a wide excision. And if you use, for example, the Tokahashi score, which was very popular, the score would be 6, which would recommend conservative treatment. Well, with melanoma now, there are targeted markers, and one of them is a BRAF mutation. And if this is present, these patients are living beyond 2 years compared to the typical melanoma median survival of about 4.2 months. And you can see in the yellow curve at the top on this Kaplan-Meier the dramatic difference if they have this mutation. Well, this patient had this particular mutation and so was treated with surgical decompression and given the various targeted therapies post-op, also given radiation post-op to the area, and was ambulating 1 month after rehab and had stable systemic disease 2 years out. So you can see the dramatic impact of targeted therapy and how we should approach these patients. This is another interesting example of a patient I had who presented to me with metastatic adenocarcinoma of the bowel and had exhausted chemo, had this area radiated, and she had severe radiculopathy and some mechanical pain. And I remember the medical oncologist telling me there was no more options chemo-wise. And so I said, well, do you want me to take some tissue, or do you want me to send the tissue for molecular profiling? And he said, oh, I guess that'd be a good idea. And it turned out matching to an antihypertensive medication. And this patient of mine is still alive 5 years later. And so it's another example of us as surgeons knowing that this targeted therapy is potentially available and maybe an option for them living longer and changing our approach to them from a surgical perspective. So I think the take-home message there is that there's tremendous advancements occurring in medical oncology on the biologic or the genomic side. And we need to know what's happening, and we need to challenge our medical oncologists about it. Now, similarly, with radiation, there's lots going on there. And certainly image-modulated or stereotactic radiation that you guys know has been going on in the brain for a long time is now becoming very commonplace in the spine. And not every center has it. And even if centers do have it, I feel there's a range of aggressiveness of the radiation oncologist. And it's kind of an evolving field. But certainly it's a field that we need to know about and we can utilize in combination with our surgery. And really what it allows the radiation oncologist to do is deliver high doses of radiation to the tumor and not to the surrounding tissue. So there is not a lot of collateral damage, which we like as surgeons because that should help our wound healing. And it can be delivered in 1 or 2 fractions, or it can be up to 5 fractions. And it's a little bit more, well, it is more time intensive for the planning. but it's better for the patient in the sense that they don't have to go as many visits for the typical palliative doses that are over a higher number of fractions. So if we go and look at kind of the indications around radiation, there's conventional radiotherapy or external beam radiotherapy, whatever you want to call it. And then there's the image modulated or stereotactic radiation. And if we look at sort of the general tumors that are sensitive to conventional radiotherapy, that would be breast, prostate, and lymphoma, myeloma, seminoma. And there's no reason to give these particular histologies stereotactic radiation because they respond very well to conventional radiotherapy, and it's certainly still an excellent way to treat these patients. If we look at stereotactic radiation, we've got tumors that were previously radioresistant, but now with the precise high dose to the tumor itself, we can render these patients or these tumors sensitive to this dose of radiation. So in a patient with no instability, resistant histology, or progression or failure after conventional radiotherapy, stereotactic radiation has a very strong indication. But there's one thing we have to be careful of when we're dealing with that, and that's the degree of epidural disease. Because when there is epidural disease there, it limits the dosing because of the proximity to the spinal cord. So if this is in the cauda equina, you've got a little bit of leeway, but certainly around the cord, as precise as they are, they have to limit the dose there. And as a result, if it recurs, it's usually in that area, in the epidural space, as opposed to further away where they can deliver higher doses. So this is a very important consideration, and it was sort of the evolution of separation surgery. And separation surgery, very simply, is getting the tumor away from the spinal cord and dura so that a higher dose can be delivered and you can minimize the cord toxicity. And there have been a number of centers, Peter Gertzbein in Pittsburgh and the Memorial Sloan Kettering Group in New York and Arjun Segal in Toronto that have really championed and pioneered and led the way in this new therapy. And the evidence for it has been fairly strong. So you've got an example of a patient with renal cell cancer and metastasis, and this was a traditionally radio-resistant tumor. So often we go through these big procedures where we do a vertebrectomy, and even in patients with isolated renal cell, we might even consider en bloc resection because some of them live a long time. But now we're able to do these in a minimally invasive way with followed by stereotactic radiation. So very simply, you go in, you can percutaneously stabilize, you can create a small Wiltse type approach to get into the canal, remove the epidural tumor, and then follow it with stereotactic radiation. And in most of the big centers now, this is the approach that is taken. I think in centers that don't have stereotactic radiation, then we still have got to rely on the bigger surgical procedures to try and control the tumor locally and get the best result. But certainly with stereotactic radiation, when it's available, it's changed the game for some of these radio-resistant tumors. Now, one question, a very practical question, was how much do you have to resect? How much room do you need? And obviously this is difficult, but Arjun's group in Toronto looked at this and they felt that at least 6 millimeters of separation from the dura was appropriate to optimize the outcome. So you can kind of keep that in mind, and I'm going to revisit this again in a few minutes so you can see it in action. But I think, as I said, it's generally adaptive. I think there's pretty good recommendations. Our group in the focus issue in 2016 felt, based on systematic review evidence, it's certainly a viable option in radio-resistant tumors. And then the last thing, of course, is MIS surgery and how that combines with the stereotactic radiation. And, now that can often be done as a daycare procedure to percutaneously stabilize someone, or with vertebroplasty, kyphoplasty, and the combinations. And these patients, because they're systemically unwell, many of them, and because some of them have had previous radiation, I'm sure we've all experienced the wound complications that can occur. And with percutaneous fixation, I think it's really dramatically changed that. So another example of why previous algorithms, previous classifications are not valid today. The other thing that's changed is SINS, and since it was first introduced in 2010, I think it's had a big impact, and the impact has really been to the oncologists and getting us better referrals. And I think it's allowed for greater multidisciplinary work in these patients. For those of you who aren't familiar with it, it is a tool that determines stability in the setting of spinal metastasis. And it was originally designed not to determine if surgery is necessary or not, but it's designed to determine if the spine is stable, potentially unstable, or unstable. And it's a scoring system here. You can see this particular patient, 57-year-old male, and he had some progressive neurologic deterioration and had an L1 fracture, was presented with Asia C, mechanical thoracolumbar pain that was very disabling, and he was in bed pretty much. And lymphoma generally responds exceedingly well to steroids and to chemotherapy. And the oncologists were planning to do that, and his neurology improved with steroids, but he still had this horrible pain. So even though it's a tumor very responsive to radiation and chemo, he was still in terrible pain. And when you look at his SIN score, going through each domain, the location, whether his pain is mechanical, the type of lesion, whether it's lytic, mixed, or blastic, radiographic alignment, vertebral body collapse, and whether the posterior lateral part of the spine is involved. His score was 13, which would suggest this was unstable and certainly should be reviewed surgically. And what would happen in the past, the oncologist would have no clue, and these patients would sit on an oncology ward and be on heroic doses of narcotics and other medications, when a simple stabilization procedure was all that would be needed to improve their pain and their health-related quality of life. So SINS has really, I think, helped that whole process. I think it's helped us standardize the assessment of patients with neoplastic instability. And I think it's also been a valuable education tool for training residents and fellows. So, there was nothing before, and now we have it. Whether SINS is valid in the cervical spine as it is in the thoracic spine or the lumbar spine, and whether the variables that we assess are a big component of it or small, we don't know, and there's further work going on. But at least it's all got us all thinking the same way, and as I said before, providing a standardized approach. And if you look at the oncology literature, the radiation oncologists are now using it on a regular basis. And I think my Friday afternoon at 6 p.m. referrals for a patient in the radiation suite going off their legs has decreased quite significantly. So it's been very helpful that way. One thing that SINS wasn't designed to do was direct treatment. It was just designed to determine stability. But one group, the 7 to 12, the indeterminate instability group, is interesting because they're the most prevalent group. And you sort of sit there like any classification and go, oh, great. It doesn't help us in this really difficult 7 to 12 group where we don't know what to do. Well, in a large prospective cohort study we finished about a year ago, we specifically analyzed this SINS group from 7 to 12. And the conclusions were interesting. And obviously with 6 domains to SINS, it's hard to weight them all and everything else. But clearly surgery in this group did much better. And the radiation results were not that compelling. You can see the minimally clinically important difference score was exceeded in 63% of the surgical group and only 44% in the radiotherapy group. So I guess the take home from this is that if you do have a patient in this group, I would err on the side of surgery, especially with mechanical pain, which I think patients with mechanical movement-related pain is a big surgical driver, and may not be the only driver, but certainly a major one. So when you're presented with this patient, I think they are strong surgical candidates. And what will be coming out down the road is determining what SINS components are important for directing treatment to help us better determine the care path with the radiation oncologist. Now, there's no audience feedback, so I don't know if we'll wait till the end to do questions, I guess. So I'll just continue on now. So that's kind of an overview of what are the kind of new things or the new approaches that are going on. So we know that the previous ones aren't valid. So with that background knowledge, it's hard to remember all the different things. So, what can we use? What sort of approach can we take so we optimize treatment in these particular patients? And what approach can we use in teaching our residents and teaching our fellows and teaching our oncology colleagues as they teach us in determining the best route forward? Well, I think just from a big picture perspective, I always look at it in 3 ways: the stability, the neurology, and patient factors. And neurology we're pretty good at. If there's cord compression, that relieving that compression generally will improve neurology. We now have SINS, and that helps us work towards whether we should stabilize these, whether it just needs cement or whether it actually needs instrumentation. And it's really the patient factor group that is the different one. And what I mean by patient factor is how are they doing their performance status. We often call it the end of the bed test, where we're just can look at them and see what is the histology. All those are patient factors that you include in your analysis. And one thing we used to ask all the time to the oncologist was, well, how long is the patient going to live? And for the most part, they had no clue. They would go, 6 to 12 months or less than 3 months, but really they didn't have any good prognostic indicators. And I found them all over the place. And it was interesting. We did Michael Failings was the PI on the metastatic epidural cord compression, which was an AO study with 10 sites or 8 sites, can't remember. And the surgical indications were life expectancy greater than 3 months. Well, and over a third of the patients died before 3 months. So we and the oncologists certainly weren't very good at predicting who was going to live longer than 3 months. And what's even more interesting is, why would we use 3 months? Why is how long the patient going to live a critical factor? Now, clearly, if they're going to die within a week, that's an issue. But generally speaking, especially with our minimal access now, can we do a minimally invasive decompression and percutaneous stabilization and get these patients out of hospital, out of pain, back home for the remainder of their time? And I think saying that patients have to live longer than 3 months to be surgically considered is wrong now. And I think all of these patients should be considered for operative intervention if the risk-benefit ratio is favorable. And we looked at this particular group, and what we found that generally their health-related quality of life was improved, and that they were satisfied, and that we haven't looked at it economically, but it would seem that it could provide some economic benefit, especially if you get these patients out of hospital, if you maintain their bowel bladder. But most importantly, you enhance their quality of life for the remaining time. So I do think this isn't all patients, but I do think the survival greater than 3 months is not an indication necessarily for surgery anymore. And this is the first evidence to really look at that. The other thing about patient factors is the performance status of the patient is important. And all the studies show that it is the key variable. The oncologists use the ECOG or Karnofsky. They're two different scales, but essentially they go from, normal to death. And really, it's just if they're ambulating, independent activities of daily living, bedbound, etc. But generally speaking, if their performance status is good, the outcome is better. And of course, histology is critical. And as I mentioned to you a while ago, not just looking at global histology, but looking at specific histology and the omics around it. So what are our goals, palliative goals of therapy? We want to improve neurologic function, and we can do that with radiation, steroids, surgery. Stability we can do with cement or implants or a combination. Tumor control with external beam or stereotactic radiation. But all these things, whether alone or in combination, is to improve the health-related quality of life in these patients. And if we look at it more specifically, this is to reinforce what I've talked to you earlier about. We've got the targeted therapy now, so we look at histology differently, and we have a real range of radiation. And even the P32 plaque, which is available in some centers where you can place this on the dura directly for about 15 minutes intraoperatively and take it off. I mean, it hasn't been studied extensively, but it's not a bad thought in some of these highly resistant tumors where you're getting recurrence. And then surgery, as we talked about before, we've got so many more options now. And en bloc, which is used sometimes for thyroid and sometimes for renal cell still, and should be in centers where you don't have stereotactic radiation is an option, but less and less. And certainly the morbidity of the procedure, the likelihood of high morbidity should rule out en bloc. But if a metastatic tumor is easily unblockable, it should be considered in certain histologies. So I think the best thing we can use now, and this is interesting, this approach was developed in 2006 by the Memorial Sloan Kettering Group and Mark Bilski, and it's called the NOMS, and it looks at neurologic, oncologic, mechanical, and then just systemic. So it's really the patient factors, stability, and neurology. But it certainly breaks it down into a good process to use, and I think this is one we teach, again, our residents and fellows. And when it comes to neurology, steroids, I think, are controversial, but generally speaking, they should be given in patients with neurologic deterioration or presenting with metastatic epidural cord compression, and they should, we give 10 milligrams and then 4 every 6 hours, and that usually buys you some time in most patients so you can get the OR organized and get your treatment plan ready to go. The other commonly asked question is neurologic recovery and how soon you should do surgery. And this is difficult to, provide recommendations or guidelines because there's so many factors that creep into it. But bottom line is if someone has neurologic deterioration, they should be done as quickly as possible. And there's a number of studies that show that the timing and that the earlier the better. So once you've determined it's safe for the patient, I think you should take these patients to the OR right away to maximize neurologic outcome. Now, I mentioned it before about the epidural disease and how that affects things, and that's the interesting thing about the NOMS. It brings this into consideration. And Mark Bilski and his group came up with this compression scale that helps guide the radiation oncologist into what they can use, when they can use SBRT, and when they need separation surgery. And essentially, it's for the high-grade epidural cord disease, epidural cord compression from a radio-resistant tumor. That is the one where you really need to utilize the separation surgery. And renal cell would probably be the most common example of that. So we've gone back, you've seen that before. We know which ones are the radiosensitive. We know which ones are the radio-resistant. And again, this is the background you have to have. As a surgeon now, you've got to understand this, or certainly know there's a difference, and be able to talk to your radiation oncologist about it. So if you have a radiosensitive tumor like myeloma, you can use external beam therapy, and you don't need surgery, and you don't need stereotactic radiation, and you'll see a very good response right away, and usually you use in combination with steroids. And then another example would be prostate. And again, external beam radiation, because it's a highly radiosensitive tumor, and you see a dramatic response to the epidural disease and no need for separation surgery. In the low grade, the Bilski 1s or 0s, and this is an example here, in a renal cell or in a tumor that's radio-resistant, you give stereotactic radiation and get a very good response, and a prolonged response, usually out to 2 years. And then if there is that Bilski 2 or 3 of the high-grade epidural cord compression, that's where the surgeon comes in and takes the tumor away. And then is followed by the stereotactic radiation. And they can usually follow right away. You know how we used to delay things for conventional radiotherapy because of wound healing? Now that's not an issue with the targeted radiation and the minimally invasive access that we can achieve. So it's a really a game changer in the treatment of these patients. Here's an example. You might think how you would treat this patient: renal cell carcinoma, 65-year-old female, a lot of pain. There's a lot of metastatic disease, so it's not an isolated renal cell met. And it's interesting, a lot of the targeted therapy does very well with renal cell metastasis, but not in the bone for some reason. We're starting to look at that and study that to see what the difference is. But often the targeted therapy does not reach the bone metastases. So in this particular case, there's high-grade epidural disease, and it's progressive. And it was a Bielski 2, so it required separation surgery. Often with instrumentation in there, they'll want to do a myelogram for planning instead of an MRI. And this is a very simple way with low morbidity to take care of this particular patient. So you don't need to go in surgically and remove the whole tumor. You just need to circumferentially decompress the cord. And we talked about that 6 millimeters of space. And the radiation oncologist will usually determine the dosing post. Like I said, you can start right away. And often they'll just do 1 or 2 fractions at the most. And this seems to have the best effect from a preventing local recurrence perspective. Here's just some schematics. In doing your laminectomy, you do usually have to take 1 pedicle down to get to the front of the cord. It's too difficult without taking the pedicle and lateral mass down, and you potentially create neurologic injury. And you release the PLL and basically circumferentially decompress the spinal cord, all from posterior laterally, in order to access the front or anterior part of the cord. And once you've done that, we use this a lot, intraoperative ultrasound. It really gives you a good idea, both in the axial and sagittal plane, that you've removed the epidural disease, completely decompressing the cord, but you do not need to go into the vertebral body or outside into the tissues. The stereotactic radiation will take care of that. So certainly, as I mentioned before, it is something that is here to stay, and something which we should be endorsing if our centers have the stereotactic radiation. One thing that you may or may not know about is this randomized trial just came out comparing external beam or conventional radiotherapy with stereotactic radiation, and it didn't show any difference. But this was for all comers. Unfortunately, they didn't sort of stratify on tumor histology, and their outcomes weren't based on local recurrence. They were health-related quality of life and pain. So there was not a lot of difference between the two. Does that mean we should give up on it? Certainly not. But it does mean that it shouldn't be used on the radiosensitive tumors, like I discussed with you earlier: breast, lymphoma, myeloma. And we need to study it more in the specific radio-resistant groups. But it's certainly something that people want to discuss. There's one more Canadian study that's also a randomized controlled trial, and this is one that is looking at specific histology, so hopefully it'll answer the question a little better. I'll just finish now with a couple of, I guess, patient evaluation tools. And like I said, it's really important to evaluate your patients, and that, you know, the interventions and that you're providing are actually improving outcome. And we developed the metastatic specific, disease-specific outcome questionnaire. And it's the Spinal Oncology Study Group originally did it, and then the AO Knowledge Forum has sort of taken it through the validation process, and it is now gone through that, and it's being done in many countries now in different languages, but it's an excellent way to evaluate these patients. And one of the things that had never been looked at before was patient satisfaction, which came out of this questionnaire and this EPOSO study that we did. And it showed that this group was actually very satisfied. You can see surgery plus or minus radiation, 84%, 11 no difference, 5% disappointed, and here are the results for radiotherapy. So it definitely shows that patients have a high satisfaction with the treatment for metastatic disease, which is important. I mean, health-related quality of life is important, but certainly satisfaction is really key. And we did a multivariate to look at variables, and interestingly, it was higher than some of our elective practice satisfaction. So interesting. Of course, it's a very different patient group. And some of the psychosocial things here that led to dissatisfaction, not having a partner or care provider. Obviously, these are very important things for patients. And one thing we're studying now as part of an AO grant that we got was to look at patient expectations. And as surgeons, we sort of know what we feel we know, or we think we know what patients want, but in reality, we don't. And this is a very interesting patient population. And this article in the New England Journal kind of basically showed that many patients who were getting, with incurable lung cancer, who were getting palliative chemo thought they were going to be cured and really had no idea what was going on. So clearly we're not communicating with patients well. And this is a pretty simple example, but if you have a certain expectation and your experience is what your expectation is, then you're pretty happy with your quality of life. If you have an expectation that is different than something you experience, you want to run, but you can only walk with a cane, you're not going to be terribly happy. So expectations is really, really important in helping optimize our outcomes. So we're doing this study. It's qualitative research where patients and physicians are interviewed to try and determine exactly what the patient wants to know and what we should be telling them. And some of the early results are that they are very, very concerned about pain and want to have expectations around that, physical and social function. They don't have any expectations around being in a better mood or happy about their surgery, because it seems that the cancer is more of a driver in that area. 70% of them were not aware if they were cured or not in this metastatic group, where all of them should realize that this is not for cure. 70% is very dramatic. And although they're very good at knowing the risks of the operation, and the surgeons are good at explaining the risks, they're not very good at explaining the expectations. And so they want to know if their pain and function will improve. They want to know if they're going to be satisfied, and we have the data to support that now. And we really need to get across the message that this is palliative and that they understand the big picture. So we need to do a better job with addressing expectations, because that'll improve our outcomes. And hopefully this will provide good guidelines when all our data is in, which should be in the next few months. So in conclusion, I think it's been decades where we didn't have standardization, we didn't have multidisciplinary work or evidence and consensus opinion. And over the last decade or so, we've really been able to do that. And I think the patients have benefited tremendously from it. As a reference, there's been 2 focus issues in spine, one in 2009, another one in 2016, which really cover the gambit and haven't changed dramatically. There's few areas that have changed, but really are excellent resource for metastatic and primary tumors. And then the spinal recommendations that came out in neuro-oncology, looking at the various ways to assess patients. As I mentioned to you before, none of the previous ones are valid. We can use SINS for stability. We use the Bilski grade for epidural tumor, Asia motor score for neurologic assessment, and the ECO and Karnofsky, they're hard to remember, but they go from dead or normal to dead and everything in between, and your oncologist can help you with that. And then using a generic health-related quality of life and the SOS GOQ, I think, are good ways to evaluate our patients and our treatment. So I'll conclude there, and we can go through some cases, or I'd be happy to answer any questions or create any scenarios.